We know that our clients in our communities interface with our community health workers, and most of them are referred to good facilities after being attended to. So this slide shows us the referral rate by community health workers. How many of our clients that are seen by the community health workers end up at a facility after being referred? We see the regions of Bunyoro and Tolo. Overall, we are not doing very well, but at least we see Bunyoro and Tolo are trying. Kampala on the other side is doing badly. There's also a lot of effort is needed in Kampala to make sure that we can scale that up. We also looked at the stock levels report, and we see Kigezi is reporting some good stocks, whereas Bunyoro and Toro are not reporting well. So we need also to probably this is also attributed to poor reporting or something, but those are the stock levels that are reported in the regions. DPT3 coverage at the national level, our target was 98%. The previous year we did badly, we didn't meet the target. Even this year, the last financial year, we did meet target, but at least there was some slight improvement from the 87% to 95%, and we see 50% of the local governments had coverage that was less, and 50% were above the national average. Measles rubella coverage under 1 year, we managed to meet targets, and this is mainly because there was a response to a measles outbreak in some districts. You will see in the maps. This is the map highlighting DPT coverage. I know it is not clear so much, but the districts in dark blue and blue, 50 districts that performed slightly above or within the national average, whereas those in the blue, is it the light blue, colorblind a bit, still need work. Measles rubella 1, that is the distribution by district, and you can see the dark blue districts doing well, above 90%. On the other side of the right, those are the districts that had an outbreak of measles in the financial year, and you see the scale up of vaccination. It did help us to achieve target. When it comes to zero dose by district, you can clearly see the rate. Those are the districts where we have so many children that are reported with zero dose, and it is not good at all because 36 districts out of the total 146 reported very high numbers. Those in yellow slightly, but also high, between 500 to 1,000 in 46 districts. HPV, we are doing somehow well. You see the greens are so many, about 117 districts actually performed above 90%. Where you see the rates, that is where we still need a lot of support to make sure that we also improve. By region, for zero dose, you can see the concentration is measured in Uganda. Actually, the two regions of Uganda, the North Uganda region and South Uganda region, where we experienced high numbers of zero dose. On the right, HPV 2 coverage, you can see that there is green almost everywhere, apart from two regions. Kampala is doing badly. We need to step up efforts in Kampala. And Busoga, slight improvement, but also below target. Malaria incidence per 1,000 population, we are at a national level not doing well. We did not achieve target at the national level, but you can see we improved by 39% from 375 cases per 1,000 to about 230 cases, and this is mainly attributed to those activities that were conducted in those regions highlighted down. By regional variations, you can see that even without us achieving the targets, there was some slight improvement by region. You can see Acholi maintained. Before they had those many cases, but they slightly reduced a bit, but the incidence of malaria is still high in Acholi, in Teso, in West Nile. On the other side, Chigezi has maintained, as well as Ankole are reporting those 4 cases. Just wanted to highlight on indicators of hypertension as a country. We are still doing badly compared to the baseline year of 1920, and there was only 3.7% reduction from the 2014 state survey. So here we need to step up. The variations per gender were not so much different. Diabetes, again, we're still doing badly when it comes to diabetes. We are way far away from the national target. Stunting levels under 5, we managed to improve a bit. Same applies to wasting under 5 as per the UDHS of 2022. But there is a lot of effort also there for us to make sure that we improve. Nutrition assessments by region, you can see the distribution and disaggregation under 5 adolescents and pregnant and lactating mothers. Chigezi, when it comes to under 5, reported the biggest percentage of the under 5s that come for OPD attendance at 95%. Whereas South Central Uganda are still doing badly. So there is an effort there that is needed for us to improve. When it comes to pregnant and lactating women, Lango is performing better as per financial year 2023-24, whereas Teso only at 7%. Sorry, apologies. This was 2020, 2022-23. This is 23-24, and we see West Nile doing very well when it comes to assessing the under 5s. And when it comes to the pregnant and lactating women, we see Chigezi doing much better, and South Central again lagging behind. Children identified with SAM. Previous year, we saw Toro having extremely high numbers at 15.1%, and Karamoja at 12.8%. That is financial 22-23. There was improvement in the last financial year, with Karamoja reducing slightly to 11.5, and Toro significantly improving from the 15 to 2.4%. We see that 2022-2023 Karamoja still maintains the highest number, followed by Pinyoro for 2022-2023. 23-24, we see some slight reduction in MAM for Karamoja, and somehow Kampala pops up with a higher number than Karamoja. So there are more MAM cases in Kampala than Karamoja in 2023-2024. ANC fourth visit, we are doing badly at national level. We did not meet the target, as well as the health facility deliveries. We failed to meet the target. But health facilities, we see the lowest district being Luka at 37.1%, Soroti at 35%, and Masaka at 33.2%. When you look at the regional or district variations for ANC 4, you find that still Gulu City has the highest at 128.7%, followed by Obongi and Soroti, as well as Jinja. The lowest being Wakiso at 25.3%, Koima at 25.1%, as well as Arua at the least performing at 18.3%. With health facility deliveries by local government, we see that Soroti city maintains the highest performance, followed by Fort Portal. Here we see that it is mainly the cities. However, somehow Butambala district local government also shows up with 134%. The lowest were still Luka, Wakiso, Madiokoro, as well as Masaka, scoring the lowest at 33.2%. Total fertility rate, we are doing well compared to the target. You can see we have maintained a steady decline from 7.4 in 1988 at where we are at 4.5. Adolescent fertility rates by years, we see that in the age category of 15 to 19, we are doing well, way below the target, which is good. This is census, the recent census report. But when it comes to the age category of 10 and 14, we see that according to the census, there's some slight misbehavior there at 0.4. So we need to do some work there. Comparison with our neighbors, we see that Uganda is only second to Rwanda. Rwanda having 31.3, but the rest of our neighbors are not doing very well, even compared to the global target of 42 births per 1,000. So HIV, pregnant women initiated on ARVs for EMTCT. We are doing well. For HIV exposed infants, there was some improvement. Though the performance was the same compared to the previous financial year, but at least we maintained, though it was way below our target. For regional variations, for maternal acts, coverage for ELTCT, we see at the national we scored 95%, but we see some regions really doing well. Toro, Nyoro, and Teso. However, West Nile, Karamoja, and Kampala still need some interventions. For art coverage, through improved linkage in communities and facilities, we performed and achieved target, whereas when it came to retention, art retention rate at 12 months, although we improved from 77 to 82, we were still short on target. So art retention by region, we see that even though we at the national level we didn't achieve the target, we see some good progress, some good achievements in Chigezi at 93%, whereas Karamoja was the least performed at 75%, but overall performances are promising, though we need to meet the 95%. TB case notification rate per 100,000 population. We see that because of caste and the community TB screening using mobile clinics has increased notification. We achieved target, although we kind of slightly declined from the previous year. We can note from the map here that there was increasing TB burden that was reported across the districts of Moroto, that reported the highest numbers with 771. On the other side, we can note that there is a shift in epidemiology of TB from peri-urban to the cities of Soroti, Fort Portal, Hoima, Aliran, and Kulu. So these cities also reported very significant numbers of TB cases. IPD3 coverage for pregnant women still doing badly, way below the target. And the reason here is late ANC attendance in the first trimester, only 73%, and stock out of supplies. Anemia screening is also one of those indicators that is where we are doing badly, and you will see the variations here compared to the previous year, where although we failed to meet the target for both years, but at least there is some slight improvement compared to 2022-23, where some regions have somehow improved, slightly improved, although the target was not met. Maternal anemia screening at first ANC by region. This is an indicator where we're doing badly across generally, but we see that at least actually is slightly trying despite the stock out of commodities, screening tests and one. There is a lot of effort needed for Chigezi to pull up. Improved sanitation coverage and improved hand washing. These wash indicators we've consistently performed well over the few years, and based on the census report, we reported 44% as improved sanitation coverage and 47% centers improved hand washing. Sanitation coverage by region, we see Kampala doing better, doing very well. However, a lot of effort and interventions are needed for Karamoja, that is still performing at 38%. Hand washing coverage, we see that Ankole is still performing better, 46%, followed by Elgon region. However, West Nile and Karamoja, as well as Acholi and Ndamo, are still need a lot of work. So thank you so much.
Thank you very much, Martin. I've seen indicators, regional referral hospital directors. We shall have a meeting with you, plus your partners, and the districts where you do interventions after lunch. We welcome Commissioner Dr. Mugahi, welcome. I was reserving this comment for you when we were visiting Mayuge under our PDM activities. Out of 103 women that get internet care, only one delivers at the facility. Most of them go to the TBAs and deliver at home because they trust the TBAs more, and more so when they go to the facility, they say they take away their placenta and they require their placenta. Okay, so we need to do a lot of sensitization in the Mayuge. Zoning. One of the objectives of this meeting is that we are zoning community health partners for improved coordination and equitable service delivery. The process has begun, and we have issued a QR code for the form. Every partner must fill that form. Must fill that form. If you are a partner who will not fill that form, you are like a Ugandan without a national ID. You will be there moving. We shall be seeing you, but you will not be having a national ID. We will not be in our records. So far, the sub-partners have submitted, and we have a record which we want to present. The process has begun. So, at this time, I would like to invite Dr. Jimmy, Senior Medical Officer in the Community Health Department, who is following up on that, to give us the presentation. The process has begun. So, come over, sir. Can you have received the presentation, please?
Good morning, everybody. Good morning, Madam PS. You're most welcome. Good morning, commissioners. My name is Dr. Jimmy Ochorinduga. I am a senior medical officer in the Community Health Department. I think we need an energizer for the presentation to come. We've been sitting since 8 o'clock, if you don't mind. Yeah. Martin has seconded. Let's have an energizer for the presentation today.
Okay, self-care, you come and give us, but the energizer must not be vigorous.
Asked me to be gentle to the ladies. Since Monday, I've been, Dr. Mugahi, welcome. And yes, happy to see you. I've been saying this since Monday that we should be having self-care observed as Minister of Health because we are the one pushing self-care. So I'm happy that when they saw Dr. Mugahi, they gave me the opportunity because we would not allow any meeting to go on without a bit of
Diabetes is increasing.
So we are just going to do a simple one. We get up. Dr. Mugahi, come on. Now is my best. The United is showing what we should do. So Dr. Mugahi, demonstrate as we go. I'm waiting. I don't know what Dr. Mugahi is doing. Yes. There we are. There we are. Good. Again. More. Yes. Good.
Because of limited space.
Yes, but yesterday we already had a panel discussion on self-care. You missed it. So thank you so much. But I request Edward that at least after every 3, okay, he always tells us 2 hours in the department, we just get up and put some music for people just to do this. Dr. Yo likes doing shakam shaka. Just can we just shakam shaka? 1, 2, 3, 4.
Thank you very much. Thank you very much. Can we load the presentation? So, following the guidance from the permanent secretary, it was clearly emphasized that for us to avoid duplication of one services, but also wastage of already existing limited resources, let's start mapping, zoning these partners that are delivering community health services. And we thought through as a department that we could do this using the strategic directions within the National Community Health Strategy. And so far, the partners that I have filled in the zoning tool have so far filled in within 3 strategic directions. I just want to quickly, without wasting time, to show the permanent secretary so far which partners are supporting which strategic directions and which regions and districts these are. Next. So the tool clearly highlights the number of projects that are so far the partners are supporting at community level, and what we have so far captured that partners that having bilateral agency funding, the partners that have so far filled in 2 projects, partners that are community-based organizations are 24, and those at international NGOs are 120, and national or local NGOs are 208, and the UN agencies, we have 15 projects that these partners are implementing. And in total, we have 392 projects that are being implemented so far within the 3 strategic directions that we're going to see. So this is by distribution. We have at national level we have 136, regional level 137, district level we have 50, and at community level, that is at sub-county and parish, we have 69 so far. So for strategic direction 1, increase availability and access, that's both geographic and functional. We have, so far those are the partners that are supporting this strategic direction. Clearly we have UNFPA covering over 33 districts, that is highlighted in yellow. Then we have USO, and in 6 districts, that is in purple, and URC, or Universal Research Center, in 34 districts, that is in blue. Then we have that are overlapping in green. For partners that are supporting the strategic direction 2, that is ensuring skilled, equipped, committed and compensated community health workforce. This really targets partners that are supporting mainly the informal community health workforce, that is the community health, the VHTs and the CHUs. We have we have in areas of training, building capacity, tooling this community health workforce. we have them distributed still. We have those 3 that are still supporting those regions, but also we have those other partners that are supporting, including those in green, overlapping. Yellow is strong minds. These are delivering mental health services at community level. And then in blue, those are malaria consortium, covering mainly the Karamoja sub-region. And then we have that in yellow, I already mentioned strong minds. But also we have partners that are supporting rehabilitation services, inclusive of POSU. Strategic Direction 3 that partners are supporting us, including here we're looking at ensure availability of quality essential medicines and commodities at community level through an effective and transparent supply chain system. So here the partners are supporting us in the supply chain across all programs, including malaria services, HIV services, NCH services, rehabilitation services, inclusive of disability interventions. And these are clearly supporting a number of districts, including, let me just get that is the map, including, you look at UNICEF, that is in yellow. As far as supply chain system is concerned, we have them covering northern Uganda, have them covering southwestern Uganda, and districts within central Uganda, covering close to 50 districts. We also have AMREF, that is in West Nile, as you can see on the chart, and also have BRAC Uganda. So this so far, yes, these are the partners that have so far zoned out, supporting those strategic directions. So for those that have not yet filled in the tools, this does not mean that these are the only partners that are supporting the strategic directions, and we are requesting and emphasizing that continue filling in the tool, because this is what the Permanent Secretary wants to see, to avoid duplication of resources, both for service delivery and the finances. Thank you very much, Chair.
Thank you very much, Dr. Jimmy. You know, I have to stress that this is very raw data. It is work in progress, but we have started. I urge partners to fill that form at the comfort of your sitting room, even if it's a Saturday and you're in your garden. These days we are digital. You open it, fill, so that you are part of us, so that we know what you are doing, because this is part of the zoning process. Now we are going to enter into a time when we are going to call upon PS, and our ask is simple. One is we request for guidance on how well we can improve. We also request for her explicit guidance on how we can continue with the zoning. We have partners here who report that, for example, Edward Interventions Organization working in Wakiso district, but when my area of coverage is Masoli village. We have those partners.
That was my question.
That's what your question. I've read your mind. So when you are filling that form, in fact, you will be the one to advise us to give us guidance. I'm doing only one parish, I'm doing only one household. We have partners who are supporting one household. We have that household, we offer disability interventions. So that's the simple guidance we have. So at this time now, I
Since I was not here when they were recognizing all the protocol, but I believe that we have all been recognized in our respective capacities. So allow me really to go straight to make my remarks, but I'm more excited to see. Can I see someone from local government? Someone from local government? Thank you very much for coming. Apart from the DHOs, do we have someone from the Ministry of Local Government? We don't have. We have? Where is that person? They are outside. They are on the phone. Maybe they are attending to calls. I would really want, before I leave here, I want to meet the representative of Ministry of Local Government. I'm also excited to see someone from the Office of the Prime Minister, the civil society, and all our leaders in your respective capacities. I see the directors, some directors of the hospital, our hospitals, commissioners. Thank you very much for coming, and thank you for organizing this meeting. You have realized that I have not come with a speech. It is intention. They made us speak, but I said, I think let me just go and make my remarks as I think that are suitable for this meeting. First of all, I want to thank the organizers of this meeting. I want to thank specifically the partners that have put in their resources. Without them, we would not be here. We want to thank the traditional partners that have committed day in, day out to support our intervention. Whenever we call upon them, they respond to our request and they commit resources. Ladies and gentlemen, let me begin with retaliating and emphasizing the importance of us strengthening the community health interventions at community level. Those interventions are being implemented in different tranches, but the community health department is supposed to be like the monitor. What is happening in sanitation, if the district set targets on this, they will be able to look at what has been done, what interventions have been done. If we are talking about the social service committees that have been put in place under the strategy of PDM, how many have we held? How many have actually reviewed the indicators that the community extension workers picked? How many interventions have been made as a result of those committees picking out the salient issues at parish levels? For example, how many parishes have actively
held the committees, and those committees, how many have received the health assistance reports on the indicators picked by the village health teams, and how many interventions have been made as a result of the commitment at social service level, at parish level. How many committees have we seen committing to follow up to the village levels, because the parish brings together a number of villages? How many of those parishes have held meetings with the villages to ensure that the health indicators that have been presented have been followed up, and we have implemented, and we are able to see the change of statistics in those villages? How many villages have been transformed as a result of implementing the social service committee strategy under PDM? So when Lukwago was coming here to present, I was so keen to see that, because I thought the community health has put together this information, and that's what we are going to see. And I did not see that. I saw more of the normal statistics that have come through different departments that are coming through to our DHIS2, and we analyze antenatal, attendance, DPT, which also UNEP has religiously been presenting to us. So what really, I was very enthusiastic to see the statistics, especially emanating from our interventions of social service committees at PDM, because we rolled out this, we met different, and every year we see how many milestones are we attaining as far as that is concerned. So I have seen that we have not done that. And for me, then that we have not done what we agreed on. On Monday, we have been having our guest from Gavi, the CEO of Gavi came over. She has been with us. On Monday, we had the opportunity to meet the head of state. And on that day, on behalf of the Ministry of Health, together with my ministers who were there and DG, and we took a thorough beating in front of the CEO of Gavi. And His Excellency said that he was accusing the Ministry of Health failing him thoroughly. That's what he said. That we have failed him thoroughly because we have failed to take up what he has been telling us, and he has been communicating in writing to us. We have got so many letters of the President, and he said he was embarrassed with us because we have deliberately refused to address the issue of malnutrition and stunting in this country. And he holds that so badly on us. When I came here, because I know that community health is housing the nutrition division. And I was so eager to see the serious interventions at community level on nutrition. Community health department has two divisions, has the disability and nutrition. And I thought really a big portion of this discussion here was going to focus on that line. I saw only two indicators, stunting and severe malnutrition, and I think mom is what? Moderate. Okay. So that's what I saw. I have looked through your program. I have not seen a serious agenda on malnutrition at community level. What are we exactly doing? Where is the Assistant Commissioner in charge of nutrition? Is not here? Or anyone from nutrition? So I heard that yesterday you had just a panel discussion. Just a panel discussion. And I think that is not sufficient. We really need to focus on the issues that will deliver results at community level. We need to change the approach. We need to change the approach. I think I really expected to come here and I see districts telling us the targets they set at community level and what they have done. That's what I expected to see here. I expected to see the partners at community level. What interventions have you done? What results have you achieved? And why didn't you achieve? And how much money did you put there? At community level. We are talking about community interventions. And we are zoning the partners on what they are doing at household, at the community, at the village. What are they doing? What resources have they put there? What interventions have they done? What targets did they have? What have they achieved? Why didn't they achieve? And then what can be done to galvanize the effort so that the implementing partners at community level are able to achieve. I expected serious discussion at community level. What are the things that we are doing at community level, at household level, to change the trajectory? The civil society are supposed to present to us how much money, what did they do, what results did they, that they are attributable to them as civil society. It's not just enough to say, we have 20 civil society organizations, we have so many UN, whatever agencies. We want to see, this is more or less like accountability forum at community interventions, at community. And so we expect the community health department to be lining up clearly civil society, implementing partners, departments, because they are supposed to be like our monitor now at community level. For you, what have you done? For you, what have you done? Last time, civil society in Karamoja enforced for us intervention. Therefore, we want to see what interventions in Karamoja, at household level, at parish development model, social service committees, as far as malnutrition in Karamoja, in Amadat, in Kotido. what exactly the social service committees are doing at that level, and what have we achieved. And if we did not achieve because of maybe resources, maybe because of other challenges, then we sit together here and say, we did not do interventions at this level because we were challenged, we couldn't do this because of this and this. Then now we get together with the partners, with the implementing partners, later in the wrap-up, and we say, here we failed. Karamoja on the malnutrition, we have failed. Why migration? Why drought? Why this? Okay, what do we do now? What do we do? Local governments from Karamoja, the theme today is malnutrition. We want all the districts, total districts, Karamoja, we want you at the table. Office of the Prime Minister that is coordinating this, what are we doing? And then we sit on the table and we bring the districts that are affected in that, and then we say, this is now what we are going to do. Then we get sanitation. We still see open defecation as a big problem. We raise this in a number of districts, and we set targets. The health educators, the representatives of those districts must come and tell us what they have done and how they have reduced the open defecation. And then we are able to say, no, here, we set targets, you have the partner there supporting you, why haven't we reduced this? And then we get on the table and discuss. For me, this is really what it means to have serious engagement on community health interventions. We still have regions that have jiggers. Don't we know them? Don't we know them? So what have we done? Those districts that have jiggers, what community interventions have we designed? Use the DHOs, use the leaders there, use the community, those committees at parish level. What have we done and on ground? What targets have we set for those jiggered communities? Yeah, it is jiggered. They are jiggered. They are jiggered. So we really need to be targeted workers. We need to be targeted workers. You know, let me tell you, ladies and gentlemen, I thought I was not going to raise my voice. I started like in a male composing. Let me go back in a composing. I keep on forgetting I'm the guest of honor. The guest of honor are not supposed to bang the tables. So let me go back. So I have seen that we are spending so much time, my goodness, in guidelines. Oh my God. What have those guidelines helped us to achieve? Guidelines, strategies, guidelines, strategies, guidelines, strategies, guidelines, strategies. Until when? Until when? When are we going to stop that and then get now on the ground and we start seeing results? I am not seeing that. Can we focus? Can we focus? I am bringing the wrath I got from the president on Monday. Together with my minister, we just looked down, we were blasted the whole session of 45 minutes. And we finished and we walked out with our tails in our legs. We got a thorough beating. Nutrition is under community health. I sat here itching to see really. I have talked with this lady, no wonder she's not even here, the one of nutrition. That tells you really that it is not an issue. How can we have such a big meeting of community health and the assistant commission in charge of nutrition is not in this room? That tells you really where nutrition lies at the radar of our priorities. That tells you. For me, I have already picked this clearly. That the writing is on the wall. I have been talking to that summary, and I am like, for God's sake, if we continue doing the normal things and we expect different results, we can't do that. We can't achieve results. We can't. But we need to be innovative. And recently I heard that there is a World Bank project that is coming, I think, under agenda, I think of the Office of the Prime Minister. Yes. Now she came to meet me with someone from Office of the Prime Minister, I think the one who is coordinating the project, that World Bank project. And I asked, so what are the priorities? If you are taking this whole loan, and one component of that loan is nutrition, what is the priority? What do we want to implement as a country for us to reduce on stunting, for us to reduce on severe malnutrition and moderate malnutrition, and iron deficiency? You have seen anemia. Do you saw? You saw that. You saw. So what are we doing? So, Madam, we are going to set up milk bank. Do you know milk bank? Breast milk bank that women breast, and then like the one of Mbali. So now that is now the project of malnutrition and iron deficiency and you know. And I'm like, what? Unbelievable, just unbelievable. And I have been talking, and let me tell you, and I am not blowing my trumpet, and the people I work with know, I don't like doing things the same way and we think that we'll get results. We must think, we must innovate as leaders, we must see what works and what does not work, and implement what works. What doesn't work, we must abandon and go to what works. I told that wonderful lady, Samari, and I said, Samari, what if we set up demonstration small gardens at facilities, those that have facilities. We put carrots, we put cucumber, we put, simple demonstration gardens on this, especially rural where malnutrition is real. The urban, we can have another strategy because in the urban they don't have where to. But in rural, we can get those small gardens. We plant and we have nutritional days. We declare every month. Mothers come to that facility, whether health center 2, whether health center 3. They bring, this one brings a tomato, the other one brings a sweet potato, the other one brings a kamonde. They come together, they look at the garden, they are taught how to grow that food, but they also cook together. Someone tells them how to prepare the food in a more nutritional way. They eat together. Let me tell you, that thing will stick to those mothers. When they go back to their homes, they will try to demonstrate what they have learned. They will start becoming more aware. If we institute these nutritional days, started maternal, whatever MPDSR, when we were having challenges of maternal mortality, this gentleman seated here understood what exactly we wanted, and he ran with it, and you have seen the results that have come out. The nutritional issues we will not be dealing with malnutrition in the country by getting loans. We cannot change the trajectory of our health indicators by getting loans and loans and loans and sitting in workshops. We shall change the trajectory of the health indicators, especially at community level. When we are in the community, people, we must be in the community. And so what I expected here is to see what is being done in the community. This forum we are having here must bring together the people who are playing some roles in the community to present to us and to see what lessons can we learn. Like what he's doing, he brings midwives to tell us what exactly is happening in the labor world. Now, and the community interventions, we need to see people, the health educators, health assistants, to come and present. And they tell us, this is what is happening. Next month, we are launching the performance indicators of health assistants. Do we have health assistants in this room? Let me see by chance. I am not saying any bad things about you. Don't worry. I just want to see that we have representation of health assistants or health educators in this room. Because those are the core people. These are the core people who would be here to tell us. We have one person. These are the core people who will be telling us, giving us reports. We are now launching the health indicators for health assistants in the community, and we are going to set targets for you, and we are going to be coming back and say, what have you done? This region has jiggers. So your target here in this area, the community must be jigger free. So that's your indicator number one. Number two, open defecation here is at 60. It must come within 1 year, want it to come down to 30. And you come and tell us that you have achieved that. The sanitation here is like this. The health facilities that are under your care must be clean. Must be clean, and you must come and tell us, out of so many samples, this is the status, but now this is where we are. So we want to, the malnutrition, especially the districts that are affected more, like in Karamoja, like I saw even in Toro. You can imagine in Toro. In Toro, where they have the whole fertile soils all over the place. But men go and beat wives and sell the food, and they end up not having the food in their household. Then we bring in gender. If the problem of malnutrition in Toro, because men are drunkards and they take all their food from the women and they sell, then we bring in gender, and then we start addressing some of those issues. So for me, really, it is good to have this fancy fancy colored slides. But it is not going to change our status. What is going to change? Next time, I wish I can be here full time. Maybe I don't know whether I will be still in the ministry. But next time, yeah, for us we transition. We are workers. We just wake up in the morning, you are not there. But if I am in the ministry, I think we need really to have a little discussion on agenda before you come up with this agenda. We need to look look at your agenda so that it is addressing the real objectives of this meeting. I am not watering down your efforts, by the way. Don't take me, I'm not that bad. No, I am a good person. It depends on how you assess. But if we, for example, we work together and we come up with a real agenda that is going to take, our discussion is going to give us a compass, and it directs us to getting real on the real issues. You will start seeing, you'll be amazed. You'll be amazed the impact this meeting, what it can do. So we need to see that I am not feeling. I am sorry. Thank you very much for organizing. Thank you for coming. I've seen a fancy program and fancy books there on the table. Thank you very much. I appreciate it. But I think we need to do a lot more. Because this is what is just not our power. The guidelines. How many guidelines have we and the strategies? Like, my goodness. Every day we are passing, in HIPAC and with Lydia there, every day we are passing and reviewing guidelines. But has it changed things? Not really. Not really. The indicators have remained. So can we now change a little? Can we engage a little? Can we take a step behind and we say, okay, the guidelines we have made. For now, let us first implement what we have. Let us first implement what we have done, and then we can come back and do other guidelines. We have become guideline-infested sector. We are infested. Actually, in Ministry of Health right now, if you are going to say like those people who have jiggers, who have big bags, for us we are infested with guidelines. We are just infested. Yeah, we are infested. So now that we have been infested with guidelines, and we need to slow down, and we've now focused on implementing now. Can we say next year we don't do guidelines and we implement? We can change the infestation. We can just reduce the congestion, and after we don't even have the space in the ministry, because all the shelves are full of guidelines and strategies and policies and what everywhere you go. You're infested with all those things. So partners, UNICEF. I know that UNICEF, you are very good. All the time they come to you to print. You are very nice. You are such a nice and wonderful partner. You are always printing. Can we say that in the next year, don't support any printing for now? Amen. Anyone coming with guidelines, first inquire from us. Because that's not our priority right now. Our priority is implementing. Even in soft copy, we can implement. So don't waste resources. We want to optimize resources. We put it where it matters for impact. Right now, we are talking about high impact activities. High impact. Can all of you say high impact activities? High impact activities. Before you leave here on 22nd, can we see the activities that you are going to come up with that are high impact? Of course, high impact, sometimes people think that holding workshops is high impact. Don't make that mistake. Don't put that one, because I will not regard that one as high impact. High impact is at community level. What are we going to do? Targeting the implementers at the community level. What high impact interventions are we going to come up in one page? We don't need many, because also when we write so many things, then we are verbose. We suffer from verbositosis. You write so many words, then you are history, and then you copy and paste. Just pick one by one. What are the high impact activities that we are going all together? Sit with you, support you, mobilize resources, get all the partners, get all the agencies that are like Office of the Prime Minister, local government, gender, that we can sit together and we say, at the community, we meet at community level. These are the things we want to. High impact. What have I said? You know, I'm like a teacher. Today I didn't come with a more. Now guest of honor officiating. No. So high impact activities. Please, Edward, Martin, and everybody. Even I hope Sarah will remain here to help. Yes, Sarah, you have to stay and please don't run. We want high impact activities that will help us to bring certain indicators, and we target and we say next year, these are the things we are going to measure, measurable. Don't jump on antenatal attendance, because antenatal attendance, we are capturing it elsewhere. Although it is your activity also, because you have to mobilize, the community has to come, but we need high impact activities. Thank you very much. Now I am a good person, I am smiling, I'm not following. Thank you very much for inviting me. I am happy to see, and we need to see linkage, the center, the region, the district, the community. Thank you very much.
Thank you, OPS, as you go back to your seats. High impact activities. High impact activities is what now we are going to plan. Even in the next agenda items, we must make sure that we patch in the high impact activities. When PS was speaking, there is a proverb which says, spare the rod and spoil the child. Once in a while she brings out the rod, and the child is really now very good. Okay, we are now going to proceed with our agenda. Don't worry about the agenda. We are going to proceed with it. We are going to proceed with it. Yes, please. OPM wants to. Yes. You want to come at the podium? Okay.
We want to organize it.
So I would suggest OPM, first have a seat. First have a seat. Yes. No, first have a seat. No, OPM, first have a seat. Yes. First have a seat. Before OPM comes on board, is someone representing nutrition? Madame Prospero? Is Madame Prospero? Team, you around? Madame Prospero, you come. You have to come and brief this event regarding nutrition, so that nutrition is not left in absence. And after your brief, we shall have a simple brief with OPM, and thereafter we shall have some break, 20 minutes for tea, and then we come back. Yes, let's do it. So, nutrition, the podium is yours. After nutrition, Office of the Prime Minister. No, they not observe what they have said. Nutrition first. Then, OPM. Briefly. Yes. Yes. So I bring the meeting to order, please. I bring the meeting to order. We are here for nutrition.
Madam PS, the Commissioners, Minister of Health, invited guests, ladies and gentlemen, a good morning to you all. Good afternoon, thank you very much. And my name is Grace Prospero Londo Kocheng, and I work as the Principal Nutritionist in the Ministry of Health. So, Madam PS, yesterday it is true, we had a panel discussion, and in the panel discussion I gave an overview of what nutrition does in the Community Health Department and in the Ministry of Health in general. So I would just like to do a recap for you, Madam PS. Okay, just briefly, what we do in community. So we have 5 components that we act on as a nutrition division, and the first one is the MyCan, where we focus on the maternal, infant, youth, adolescent nutrition, and we do trainings at community level for VHTs, CHUs, and even at district and sub-regional levels, so that they are able to translate the nutrition skills that they've been given to the communities. And our focus is mainly on mothers, so that they learn how to feed their children better to reduce malnutrition incidences. We've also introduced what we call the family work, so that at household level, the mothers are able to identify malnutrition in their children. Each mother is supposed to be given a MWAC tape at household level. When they go to the health facilities, these MWAC tapes are available at the health facilities, and in some areas where the partners are supporting, these MWAC tapes are also given to the VHTs. And this MWAC tape now has 2 components. It has the mother's component and the child's component, so that we don't only identify nutrition in infants, but we also identify for the maternal, so that we don't miss in any case. Madam Commissioner, we are also rolling out the micronutrient supplementation. We have been using folic acid, but we feel that the micronutrient supplementation is a better alternative, and we're beginning to roll it out. And we're not only rolling it out to mothers, but we'd also like to roll it out to the adolescents to avoid the anemia that is still a high incidence in this country. In addition to that, Madam PS, we are also driving for fortification, so that we have fortification of vitamin A, vitamin D, and other micronutrients to avoid micronutrient deficiencies in the households and in Uganda in general. Okay, Madam PS, the other high impact.
We set out as the nutritional department. We targeted so many districts, and these districts, we trained the extension workers. So many, we gave them this skill, and as a follow-up, after this is an indicator of where we stand. But now you are just saying to teach mothers, it's very broad. We can't measure that.
Okay, my apologies, Madam PS. I think I need to make a short presentation on that, because it's quite a big presentation. But we have targeted about 18 districts, and in all those 18 districts, there are populations that we have targeted. Thank you very much.
Thank you very much, Nutrition. Madam PS, we shall improve.
We need to, first of all, utilize the government structure that we have. The structure that we have, at the ministry we have that division, but that division is understaffed. It cannot be in the whole country. It's not possible. You work through your structures. And the structures, you use the structure at the regional referral. If you have a nutritionist, then that nutrition brings together the people in the districts, the focal people on nutrition. Then you come up with targets for different, because each region has a nutritionist and represents a certain number of districts and even general hospital. Now those people are tasked to go down and with each district set targets on nutrition. When you set targets, who are the people going to implement? So what I don't know is whether through a DHO, you work through a DHO to the district for nutrition issues, or you work through the health educators directly. So those people are supposed to set targets through the community social service at PDM. PDM is not just about money. It is about service delivery. It's about improvement on the well-being of the people. Now, the health educators working with that whole structure is able to mobilize and bring together the extension workers or VHTs and train them, give them targets, at least visit, if you are to visit your household, at least report to us every month how many you have maybe trained on nutrition, how many have you assessed, how many have had the interventions that you want them to. Then you bring together, you put all this information together, and then it comes to the national level. We are not feeling it. We are not. No wonder the president is extremely annoyed with us. He said if he had a way, he would even dissolve the ministry. Because we have failed him on nutrition. If he talks about nutrition, he can talk even for 1 whole hour. And we do not see this as a big agenda in community health. This is your department. We don't see that. You are just giving us, statements. We didn't come here for statements. We came here for facts. The transformation that is being done at the household level.
Thank you so much, Madam PS. Your guidance has been noted, and we hope that next year we shall improve. Thank you.
Okay, thank you very much. So we need evidence that some activities are being done. So I would request the crew which is showing us the video of the activities towards parish development model, village health committees, to put them on, and thereafter we shall have, these are short facts. So can you show us the videos, please?
Improvements made in community health are contributing significantly to Uganda's regional health outcomes. Through the National Community Health Strategy, the Ministry of Health is extending person-centered health services closer to individuals in rural and urban communities across Uganda. Mr. Makumbi Ramsai's home is one of the model family homes that was chosen in Bunya County in my district as a role model. He says the community no longer suffers from communicable diseases as they used to.
Okusinziira bwe tujja mu nkiiko ezaaba tukyaga mu kitundu kino naye mawanyobula twatuka okumanya nti omuntu okubaawo obulungi ate okubanga muyonjo okuviirala ku ye mwene n'ebyakozesa n'okusingira mu maka kuba ennuma eyo tubayitulira endwaire nningi ino eziruma ebitumu n'amaka galyamu ebintu kano nebalekamaale kubanga okunagala okukandi notera okukosa abantu nemalezwatuba kinayiga ekyabantu kinage nakuliwata amaka amatuzi okuba amatekere oba nekokozi katinesa katinze erinombenene
A tour around his reforms, which include main house, gardens, Ministry of Health is working closely with village health teams and civil society organizations to increase access to health services.
And so this national community strategy is factored in with one other strategy direction, which talks about empowering community for better health outcomes and accountability. In other words, taking this arrangement of creating health in the community, placing it in their own hands so that they are able to own it as they participate, but also be able to account to themselves as the people and the leaders of this account.
Community dialogues are used as one of the tools for increasing social accountability and improving health-seeking behaviors among community members. These are held to get feedback from the community members who are benefiting from the program. One of the husbands at the community dialogue expressed concern about side effects associated with family However, Livelihoods has trained more ambassadors who reach out to men in their spaces to tell them about the advantages of family planning.
Abana bazaira abato kyalo kyaife abana bafune muto abana badufira na kumadwaliro bajja walingira omwana imagine omwana nga muto ayigalira omuntu wayagana ngati bana akanja agemeire wano mukwawa imagine banange akanja agemeira kisa kintu ekyo kyababinga mu disitulikiti eza nnyo okutuwa ebikola naye tebikyamala kino kituwa ekyokuyiga ngaffe abasoga mwena tulina okwenyigirawamu okusengeka ku zadde tubeere ne busobozi
integrated community health platform also supports maternity health through providing mama kits to expecting mothers.
People know that, of course, we are having what we call as okay? And that's why we are in this facility. But one of our main focus is our household using what we call a delivery structure. And this delivery structure is also headed by a health assistant who supervises this community health worker who is called the village team. And the village team, we all know that it's a home visitor who visits the household. We have a lot of components, and these components are one, interact with the household, and also establish the needs the household requires. They might need water and sanitation, establish the challenges that are within those households, especially these challenges, but focusing ourselves on the elements of primary health care.
Mothers are also encouraged to fully immunize their children. Cleaning of business centers helps the community members to run a safe and secure environment. For example, restaurants. And facilitation so as to increase their use.
Okay, thank you very much. I now interrupt the video because of time, but that video, we recently had parish development model activities. You know, we are focusing more on the social services activities. Madam PS, we have had a lot of challenges with Ministry of Local Government. Commissioner is still engaging Madam PS. Okay, she's listening. So, Madam PS, we have had a lot of challenges now that we are discussing with Ministry of Local Government, and we need your help. We have tried as much as possible to activate the social services committees. We needed a letter from Ministry of Local Government signed by the Parish Development Model Secretary. It's good Honorable Kalisa is coming in tomorrow. I thought that when I was playing my puzzle, I thought you would arrive at the same time, but it seems I'm a bit defeated because it's still with the President. So, we needed a letter to activate all the social services committees because we cannot use the letter signed by our PS because Ministry of Health is not having the mandate over PDA.
Social services are already there.
Now, when you get the opportunity now to use it. So I've used the opportunity of this forum. And the good thing OPM is here. But we have gone ahead to activate some social services committees as we are waiting that letter. Some of them have started working. But now that you have guided that we need to start high impact activities, we are now going to engage with here through OPM, and we shall get that later.
Even tomorrow, that we
are working towards that. So I think we OPM wanted a chance. Okay. So can we agree, since we are in a discussion, can we agree that you use less than 5 minutes? Because I'm dictating because I'm the director of programs of the city. Less than 5 minutes. Okay, okay. Can you come at the podium? Very good.
Thank you, Director of Programs. And I would like to inform you that I'm representing the lead of government business. Your program is the organizers of this conference. So I will start by posing questions. I want us to reflect on the word impact. We'll reflect on the word retreat, what it means, what is a community, what is health. There's a Nyankole proverb that says, Wakana katajenda kajira mumawena tekaji. I don't know who can translate that. Director of programs kindly translate. Why I'm saying this, I've been interfaced with the health sector, I think for now 27 years. When I was training in the medical school, when I did my internship, I worked as a doctor. I did my MPH, and my big sister, Dr. Yatika, was one of my supervisors when I was doing my MPH. And when I also, and throughout my work life. And I spent most of the time interfacing with the health sector. But when I moved out of the health sector to my current job, that's when that proverb became very meaningful to me. I used to think that I was doing the right thing. But now my perspective is very different. It's very broad because of where I am working. And let me also, I have had an opportunity to be supervised by the finest brains in this country. I've mentioned Sarah, but Professor Wabile was my supervisor, Professor Serada, Professor Sewa Nkambo, Professor Kanya, and Professor Suluma was my immediate supervisor. And when I talk about Professor Tulpai, and I'm very glad that he supervised me. And I've learned a lot. I learned a lot from him. So he used to say that planning is indispensable, but plans are useless. And thank you, Madam PS, for alluding to that. Because we spend a lot of time planning, actually 90%. I don't know, somebody can go and do a study. But 10% implementing those plans, and that's why most government programs fail. And I'm saying government. The private sector does the opposite. If you ask this hotel, who rents space here? It is government, not the private sector, government. And you wanted me to talk about OPM, about PDM, sorry. So let me pick my phone. I just want to read verbatim so that I don't waste time. My phone. Thank you very much. And I also want to make an observation that in a retreat is not a monologue activity whereby you talk and we listen. You are supposed to do more listening. So let me talk about PDM. And I've gotten this from the forward of the PDM guidelines. And I know the Secretariat is coming to talk about PDM. And that Secretariat was put in place to implement that national flagship program called PDM. But yesterday I told you that I participated I was one of those people who participated in its information. So let me read the forward from His Excellency, the Fountain of Honor, Yoweri Kaguta Museveni. And it's from the guidelines. And it says, fellow countrymen and countrywomen, under the leadership of the National Resistance Movement, which is the government in power, we have laid the foundation for socio-economic transformation by securing the entire country. Building roads, hospitals, schools, water sources, dams, generating electricity and other public services. And it goes ahead to say that during the recently concluded elections, the recent elections, that we promised that the 2021-2026 term is going to be a standard for creating wealth, jobs, and incomes for all Ugandans. In our manifesto, the NRM manifesto 2021-26, the NRM promised to use the parish development model PDM as a strategy. By the way, you can call it a strategy, you can call it a flagship program, you can call it a special purpose vehicle, you can call it anything, depending on your perspective. So, and he says the strategy to reach the households that are still in subsistence economy, to support them to join the money economy. These guidelines, therefore, have been prepared to direct the implementation of this transformative intervention. Through the parish development model, we are going to move the 3.5 million households that are still in subsistence farming to the money economy. 3 million households, it's called a true north. I don't know how I can. A true north is, you can actually put it in fact. True north. When you reach there, you know that you have got a true north. And yesterday, I was very disappointed when I asked the question about a roadmap, and somebody actually diluted it to a timeline. I was not happy. So the true north of the PDM is to transition 3.5 million households who are in subsistence economy, the money economy. That's the target. And so, through the parish development model, we have already talked about the target, and the money economy using Operation Wealth Creation, the PDM, and he goes ahead to say that using the Operation Wealth Creation, the NRM government was able to reduce the proportion proportion of households working only for stomach. And if you have listened to the Fountain of Honor, he stresses that. He says, for so many years, households have been working only chigachonga for the stomach. And he says, we want to work for stomach, but also sell some surplus. And not only working for stomach and selling, but we also need to put chibalo in this. And if you have observed where he asks for chibalo. He asks for chibalo, those farmers that he's building and beneficiaries of the money, which is a very small component of the financial inclusion of the people. And the parish is going to be the vehicle for data gathering. The data people, take note. Area-based enterprises, selection, provision of financial services, provision of basic infrastructure. By the way, I have not heard the word parish. Since Monday, I've been here, I've not heard the word parish being mentioned. Not the word. The parish is going to be the vehicle for data gathering, area-based enterprise selection, provision of financial services, provision of basic infrastructure, particularly roads, electricity, as well as community mobilization, mindset change, and social services. Where you belong. The parish will also be the focal point for services, including health. But here he dealt more on agriculture, soil testing, quality farming inputs, extensive service extension services, and mechanization. The PDM will further help us to deal with the high post-harvest losses, bulking and marketing of agricultural produce, elimination of middlemen that have been exploiting our people by offering low commodity prices and ease of access to markets at local, regional, international levels. The PDM is the whole of government, whole of society. Kindly note those words. They are very key in what we discuss. Community health. You need a whole of government, whole of society. If you get the definition of community and health, correct. Whole of society, whole of government approach to socio-economic transformation in a consolidated and comprehensive way. The PDM, we are going to, through PDM, we are going to take government closer to the people in a more effective and in a more effective way and receive actionable feedback from the people on wealth creation and government provided services. Government, we are all employed by government. And not the word, we are taking government close to the people. Yesterday I was boasting that I was one of the people who participated in those initial discussions of PDM birth. My boss, let me say, Professor Swima, former boss, used to say that government is 5,000 feet from the citizens. In the clouds. And decentralization was meant to take government closer to the people. But decentralization has also not yielded much. And he used to say local governments are 3,000 feet, and he would say those things in front of the president. I think I am in charge of you. So don't show me. Let me first say what I want to say and finish. I'm still reading this. The local governments are 3,000 feet. So the PDM was meant to take government closer to the people, using the parish as the last mile unit of service delivery. Now, that is about PDM. The others are coming. I would wish to end there, but just for information, Madam PS, there are best practice programs or interventions that are using the whole of government and whole of society approach. The nutrition program that you that you had concerns about. Through the UNAP, the Uganda Nutrition Action Plan, UNAP 1, UNAP 2, is using a whole of society. And we recently had a meeting, a review meeting at Ministerial Hotel. I chaired the morning session that was meant for the health sector. And the commissioner, was there. She was the most senior person from the health sector. But the whole of government was there, and we made commitments in terms of improving nutrition using the whole of government approach, and those commitments are available. And that is one of the best practices. The other one is the health commodity supply chain. You are aware that ERA used the intersectoral approach to develop the 10-year roadmap, which is hosted under OPM. And recently we had the first part of the 10 years reviewed, and the report was actually signed off by the sector, and we are very glad. We also have the multi-sector accountability framework for TB, which is also used in the whole of society, and we are glad that you recognize us as a stakeholder. We are hosting it. And most recently, malaria mainstreaming, which is also coming from here, the first track. And I would like to end by saying that community health, since it is a whole of society, whole of government, we'll be glad to host it. Thank you.
Thank you very much. Now, you know where PS was supposed to open this event official. We went into discussions. I'll request PS just to make one statement. I open this event official. Yes.
Now I declare this meeting open.
Then afterwards, since we are performing, you are performing that ceremony opening the meeting officially, we shall go for the protocol. We shall go for the photograph. And then after lunch is ready, PS will go for lunch. Because PS has very important engagements she's going for after her lunch. So we shall select a team. I think the photograph can be done here. We go outside or
outside for pictures.
We go outside because we are very many. Outside. So we go outside for a photograph. Dr. Mugahi, you lead PS to the photo booth, then lunch is ready, and thereafter PS will go.